Good morning. My name's John Etherington. I'm a consultant physician and the head of Defence Rehabilitation, and I have experience in rehabilitation in other communities, including the National Health Service. So Defence Rehabilitation is a medical deliverable which is unique in many ways, and it has very much a vocational focus. So we are about improving the fighting efficiency of the armed forces, both in terms of the physical component, in other words, having as many soldiers, sailors and airmen fit to fight as possible at any given time, but also in terms of reinforcing that moral component, in other words, ensuring and assuring service personnel that if they are injured, they will receive the best rehabilitation to get them back to fitness or transit out of the forces. And therefore, our main effort is around maximising the ability to generate a force fit to fight. We also want to reduce the cost burden on the armed forces of injury and illness, and we're very much focused on that. What I would say is that we have a track record of success, and I believe that the recent experiences in Iraq and Afghanistan has shown that defence rehabilitation is a very effective programme which is unique, certainly in this country and probably internationally as well. I've worked on attachment as a National Clinical Director for Rehabilitation for NHS England, so I'm aware of the NHS spectrum of treatment. And defence rehabilitation is quite unique in a number of ways. First of all, it's very broad. So we cover musculoskeletal injury, and we cover neurological injury, including severe traumatic brain injury, and the complex trauma injuries which you've seen as a result of Afghanistan, such as multiple limb loss. Together with that, it is an integrated service. So we have a primary care service, an intermediate care service, and a secondary care service based at Headley Court, together with a deployed operational service. So it's a very integrated, broad capability. Again, quite uniquely, we are involved in all aspects of the domains of military health, including promoting health, preventing injury and illness, protecting and treating at the end. And I chair a group which looks at musculoskeletal health and advises the Surgeon General on how do we prevent musculoskeletal injuries as well as enhance musculoskeletal health. We are aware that reducing the burden of musculoskeletal injury is not just a question of reducing training load, because we need to get people as fit as possible to fight. However, it is about improving how we deliver that training. It's also about how we improve the general health and well-being of the individuals, because we know that determinants of musculoskeletal health are also general determinants of health as well. And I'll come back to that in a moment. Musculoskeletal injury, although it's not the most glamorous, if you wish, element of what we deliver, is the bulk element. So we have approximately 400,000 patient contacts a year within defence rehabilitation alone in terms of delivering management. The bulk of that is in basic musculoskeletal injury. It's a big burden to defence. This is an arduous occupation. There's a lot of physical training involved, and people, particularly in those physically demanding aspects of the service, are at risk of injury. So 19% of the population in defence will have had an MSKI, musculoskeletal injury, in the last 3 months. 60% of Army medical discharges are due to musculoskeletal injuries. Over 70% of consultations in primary care are due to musculoskeletal injuries, and it's a significant burden in terms of cost, both in terms of medical delivery and in terms of things like armed forces compensation. So a big area to help in terms of prevention and management is in musculoskeletal injury. So the areas we are looking in are really not just about the rehabilitation. Rehabilitation here, we're talking about the prevention of injury as well, and maximising our ability to train our service personnel to the highest level possible without undue injury. So one of the areas we're particularly interested in terms of prevention is understanding the physiological burden on our troops in training. So we've heard that there's a large turnover and a large recruitment effort to get people in, for example, into the army. It's around about 10,000 people a year. Do we train those in the most physiologically apt way? And can we observe and monitor these individuals in a way which improves that physiological performance? So can we use ideas and equipment that, for example, are used in professional sport to monitor people's physiological output and tailor that training to that individual? Likewise, can we use that technical knowledge in an innovative way in terms of determining how we deliver rehabilitation to our patients once they are injured, either with musculoskeletal injuries such as back pain or multiple limb loss or traumatic brain injury? And so, in other words, can we use the telemetry and the other techniques that we see, for example, in professional sport, to monitor that progress and training? Defence rehabilitation, again, is quite unique in the sense that we focus heavily on exercise-based rehabilitation. And if we're not sure what we're delivering in terms of that physiological demand, how can we be certain of the outcomes? We would be interested in knowing how we improve resilience, both physical, psychological, and emotional, in recruits, both in training, but also once people have been injured. And finally, we're interested in understanding how we promote the general health benefits which we know impact on musculoskeletal injury and its prevention. In other words, the big determinants of musculoskeletal health are the big determinants of health generally, in particular things like smoking, obesity, alcohol usage. How do we inculcate in our personnel that these are important in terms of improving their health, reducing their musculoskeletal injury, and making them more effective at their job, beyond putting a poster up somewhere? We understand that we don't know everything about the factors which predict musculoskeletal injury, but I would say that we're fairly sophisticated in our knowledge of the subject, and we have done a lot of research in this area, but we would very much welcome new, innovative approaches to that. We're looking for solutions which help both the prevention of injury and the management of it. And in terms of resilience, we're looking at personal resilience, we're not looking at organisational business resilience. And that's it. If you've got any questions, I'm happy to take them now. My team is available for questions this afternoon.